Hello, I'm Dr. Nina Kim from the University of Washington. In this mini lecture, I will be discussing an update to the screening and management of clinically significant portal hypertension, and we'll be drawing primarily from the 2024 AASLD guidelines on this subject. Let's start off with a case. A 45-year-old man with HIV and chronic hepatitis B presents for care. Both infections effectively suppressed on tenofovir, alafenamide, and trocidobine, and dolutegravir, with a normal liver panel. On exam, he has a firm non-tender liver edge, but no appreciable splenomegaly or spider angiomata. Lab data is notable for a platelet count of 135, and he's found on transient elastography to have liver stiffness of 34 kilopascal. So what would you do next? A. Refer the patient for esophagogastroduodenoscopy, or EGD. B. Start carvedilol 6.25 milligrams daily, then twice daily. C. Evaluate for reversal of hepatopetal venous flow on ultrasound. Or D. Plan for repeat elastography every 2 to 3 years. I'll have you consider your answer to this question, and we'll be returning to this case and the correct answer momentarily. In patients with cirrhosis, portal hypertension is a major complication and often the first signal that liver disease decompensation could occur. With the accumulation of fibrosis, the sinusoidal architecture of the liver is fundamentally changed, and with this comes an increase in the intrahepatic vascular resistance. And like a garden hose that gets stiff and clogged with debris, the pressure just builds up behind it, resulting in portal hypertension. The clinical manifestation of this is typically ascites. Sometimes we can get an indication this is occurring via imaging when we see an enlarged spleen or when we see varices, which are swollen veins in the stomach or esophagus, by endoscopy. Or much less commonly and more invasively, we can measure the hepatic venous portal gradient by transjugular catheterization and sinusoidal wedge pressure measurement. But clinically significant portal hypertension can now be determined through non-invasive measures. Vibration-controlled transient elastography, otherwise known as FibroScan, is an office-based non-invasive test that was first developed to estimate fibrosis in people with chronic viral hepatitis. The liver stiffness measurement was found to have good concordance with liver biopsy and an accuracy in the range of 85% for detecting advanced fibrosis. But we can also determine with reasonable accuracy through the kilopascal value whether an individual with cirrhosis has clinically significant portal hypertension, or CSPH for short. There are times when the liver stiffness does not correlate as well as can occur in significant obesity. Compared with a lean patient, the predictive value of this test can drop down from greater than 90% to 63% in obesity. We can also see higher stiffness values in conditions with significant liver inflammation, such as very active hepatitis B or autoimmune hepatitis. We can use liver stiffness with reasonable confidence to risk stratify patients in this way. We use the LSM value combined with the platelet count. Platelets tell us what is happening downstream. As portal hypertension worsens and the blood backs up into the splanchnic circulation, the spleen becomes congested and enlarged, which leads to the sequestration and destruction of platelets. So using these two measures, liver stiffness and platelets, we now have validated cutoffs to define CSPH using the rule of fives. At less than 10 kilopascal, we can confidently rule out compensated advanced CLD, which is essentially cirrhosis. Moving up to 15 or greater, we officially rule in cirrhosis or CACLD, and these folks need monitoring. A liver stiffness greater than 25 kilopascal, we can confidently rule in CSPH. This ends up being a fairly major benchmark with a positive predictive value of greater than 90% for CSPH. So what about someone who falls in the gray zone in the rule of fives? Well, that's where the platelet count comes in to help differentiate CSPH. We now have an updated algorithm for determining clinically significant portal hypertension through non-invasive means using a combination of imaging, routine CT or ultrasound, where the presence of ascites or collaterals or reversal of hepatopetal venous flow can make the diagnosis. In the absence of these findings, we can also do so by liver stiffness with platelet count. And of course, anyone with clinical decompensation event, such as variceal hemorrhage, should be considered to have CSPH. So let's return to our case. This patient has an elevated liver stiffness measurement of 34 kilopascals and a reduced platelet count of 135. The correct answer here would be to start carvedilol 6.25 milligram daily, then twice daily. Based on these data elements, we can confidently say that he has CSPH and needs to start non-selective beta blockade. A liver stiffness measurement greater than 25 kilopascal, we can confidently rule in clinically significant portal hypertension. So our new approach to portal hypertension care effectively bypasses endoscopy. And our new goal is no longer just about preventing variceal bleeding as much as it is about preventing decompensation and determining who has CSPH and could benefit from non-selective beta blockade. Because we have learned that this therapy not only prevents varices, but can prevent the emergence of ascites as a decompensation event. The PERDESI trial is a landmark study that enrolled patients with CSPH as the target population. These were individuals who had no or small varices. They were randomized to propranolol or placebo, and propranolol non-responders were subsequently randomized to carvedilol versus placebo, with the primary outcome being decompensation or death. And the results were very impressive. The cumulative incidence of decompensation or death during follow-up was significantly lower in the non-selective beta blockade group than in the placebo, with a hazard ratio of 0.5. The difference mainly due to a difference in appearance of ascites, with 20% seen in the placebo group and only 9% in the non-selective beta blockade group. The one caveat to the study was that CSPH was determined by hepatic venous portal gradient and were not selected for inclusion by non-invasive means. There are 3 options for non-selective beta blockade: propranolol, naldolol, and carvedilol. The AASLD guidelines call out some key advantages with carvedilol. It is in fact the simplest to use. There's no need for extensive dose titration as there's no heart rate goal, and with this comes a lower pill burden. Carvedilol, in contrast to the other options, exerts a more effective hemodynamic response through anti-alpha-1 adrenergic activity and nitric oxide release, which induces intrahepatic vasodilation, which further reduces portal pressure. But some patients with cirrhosis can have lower blood pressures that may limit carvedilol use. Low systolic blood pressure, less than 90, could reduce renal perfusion and increase the risk of hepatorenal syndrome. In patients who have low arterial blood pressure with low doses of carvedilol, one may consider a switch to propranolol or naldolol, which may be better tolerated. Just a reminder that some patients should not be given non-selective beta blockade, including those with asthma or bradyarrhythmias. So what if transient elastography is not available, or the person has a contraindication or intolerance to non-selective beta blockade? Then you revert to the old approach of endoscopic surveillance. Patients with cirrhosis without varices on initial screening endoscopy should have endoscopy repeated every 2 years if they have an ongoing liver injury or associated conditions such as obesity and alcohol use, or every 3 years if the liver injury is quiescent or resolved, such as after viral elimination or alcohol abstinence. So in summary, you can risk stratify patients with cirrhosis to assess for clinically significant portal hypertension using transient elastography and platelet count. The presence of ascites, portosystemic collaterals, and reversal of hepatopedal portal venous flow on imaging is also indicative of CSPH, and an individual found to have this through the above criteria do not require endoscopy for varices screening. They can just start non-selective beta blockade. NSBB has been shown to prevent decompensation, not just variceal bleeding, and carvedilol is the preferred agent due to ease of use and efficacy. If you'd like to do a deeper dive on portal hypertension and related liver complications, please be sure to check out our Hepatitis C online module with related lessons. Thank you for tuning in today.
The production of this Hepatitis B online mini lecture was supported by funding from the Centers for Disease Control and Prevention.